Hi, I'm Billy Anderson. I want to go over some information regarding tracheostomies and laryngectomies, just to give a better understanding of what they're all about. Some indications for a tracheostomy are the inability to protect one's airway, neurologic disease such as ALS or muscular dystrophy or Huntington's. Um, need for prolonged mechanical ventilation, improve secretion management, although you don't see it specifically because of secretion management typically, but other ones are for upper airway obstruction, like bilateral vocal cord paralysis or severe obstructive sleep apnea or severe COPD. Sometimes they'll get a trach emergently because they're unable to intubate someone. And also they're trying to facilitate the management of a patient with head and neck trauma. Now basically a laryngectomy is performed because there's laryngeal cancer and there's need to remove the larynx. A laryngectomy versus a tracheostomy. So trach patients can still pull air from their nose and mouth into their lungs, but laryngectomy patients can only breathe through the laryngostomy. Basically, the nose and mouth are bypassed, and the trach is tied directly to the neck. So they're called, quote, neck breathers, unquote. And then that means endotracheal intubation is impossible through the nose and mouth for a patient with a laryngostomy. Tracheostomy patients can speak with the use of a Passet-Muir valve or a cap, or just occlusion of the trach. Laryngectomy patients will need a substitute larynx to speak. Sometimes they'll leave a little airway, a little area where a little air can get up through the vocal cords if the vocal cords haven't been removed. Other times they need an electronic larynx. Specific trach tubes, the Bavona TTS. I have one here. So this is the Bavona TTS. This is the obturator for it. Let's see if I can get it out of there. So this is a very flexible thing. Here's your pilot balloon. This is only filled with sterile water. You don't want to fill this saline because saline causes the balloon to leak. And you have to, I'm just going to fill this with air just to give you an example. You can see how and I'll show you the other balloons here. This balloon is kind of flush with the trach itself. It's a very flexible trach. These do not come with inner cannulas. And in order to let someone speak, you have to deflate the balloon completely. They do come with caps, so you can put the cap over the opening, and then a patient can try to speak, and the air goes up around the trach and through the vocal cords. Now, the Portex and the Bavona are the same size, like it'll say 7 Portex. That's the same size as a 7 Bavona. Same, it's the inner diameter that they're using as the size. But a Shiley has different sizes altogether. So a 7 Portex and a 7 Shiley are not the same. A Shiley tracheostomy tube, and I have several examples. This is an extra long Shiley, and this is a proximal. So proximal means this length right here is longer, and that's to get through thick neck tissue. This one has a cuff, so there's your pilot balloon. This flange is a little more inflexible than a Portex or Bavona. And here's your obturator. You just put this in here like this, and that leaves this little area here, so when you go to put it through the stoma, it's a little easier to get it in. Now you see this balloon is quite large, and this balloon is actually filled with air, and you just put some air in it until the person can't speak, and then when you deflate it, you just pull all of it out. But this balloon is a little bit larger, and so it's a little bit more difficult to get in through the stoma. The extra long trach has a different inner cannula, very flexible, but sort of a different, and this one actually locks in. This is not a disposable inner cannula. This is a reusable. Oh no, this is actually it's not. It is, sorry, it is a disposable inner cannula. So disposable inner cannula, you unlock these, throw them away, and get a new one, and start fresh. The other, I have another trach tube. So this is a number 4 Shiley disposable inner cannula with a balloon. Here's your pilot balloon, and this comes out. This is a disposable inner cannula. You just throw it away. And the obturator. Now, you have to take the inner cannula out to get the obturator in. But there you go. And you see it passes through here. And then you can't bag a person without the inner cannula in on a Shiley trach. So if the person doesn't have their inner cannula on a Shiley trach, you're not going to be able to bag them. So it's always very important that we use these inner cannulas. The next Shiley that I have, this is an uncuffed, but this is a fenestrated trach. So you see this is the fenestration here. Air will come up through there, and they can speak a little more easily. And you know, this is like somewhat flexible. But this one has the non-disposable inner cannula. So these go in and they lock into place. And then you take them out and you scrub them and you put them back in. And there are several different. This inner cannula is actually fenestrated. If you can see that hole there, right there, that goes along with the fenestrations here. The one challenge about a fenestrated trach is when you go to suction, sometimes the suction cannula or suction tube will get locked in this cannula, and you'll have a little bit of resistance there. But this one also comes with a cap. So you just put the cap, screw the cap into place, and it blocks any air from passing through here. So then the patient has to breathe through their nose or mouth. And then that's it for my Shiley trachs. The distal, so you have the extra long trachs. There's the extra long trach is proximal or distal. Proximal meaning that it's to get through thick neck tissue. Distal is to go a little deeper down into the lungs or into the trach. Again, the balloon is only inflated with air on a Shiley trach. And you can partially deflate the cuff for speaking with a Shiley. The Portex trach tube, let's see. Here's the Portex. Is very flexible, similar to the Bavona. This does come with an inner cannula. This inner cannula you put in here like this, and then there's a little thing, you just grab a hold of it and pull it out. And here's the obturator for it. It just goes in there like that. And if you look very closely, let's see if I can get it up there. You can see, it's hard to see on it because it's clear. It says Portex, and it gives you an inner diameter size, which is the size of the trach, and an external outer diameter, and then the inner cannula size as well. All the trachs sort of have some markings on them to tell you what kind of trach it is and what size it is. The balloons on a Portex trach are inflated only with air, and you can partially deflate those cuffs for speaking. Again, the flange is soft and pliable as opposed to the Shiley that has a more rigid flange. The tracheostomy tubes on the unit will almost always have an inner cannula. Bavonas don't come with an inner cannula, but every other trach will have an inner cannula. And this is a safety mechanism because if your airway gets occluded with secretions, you just pull that inner cannula out. And if it's a disposable inner cannula, you throw it away and put a new one in. But that opens the airway up. If they're non-disposable, which is rare to find on the unit, you take them out, scrub them, and put them back in. It is, like I said, rare for the trachs to be non-disposable inner cannulas on the unit. And again, not all trachs have a balloon. You look for a pilot balloon, so you look for this balloon on the outside to know if the trach has a balloon. If this isn't there, neither is this. As in, see, there's no pilot balloon and there's no cuff on that trach. Then you have Passé-Muir valves, caps, and HMEs. I don't have a Passé-Muir valve, but I showed you this cap that just twists into place here. It's a Passé-Muir valve is also a specialized cap that attaches to the opening of the trach, and it facilitates speaking. So air can be inhaled through the valve, but when somebody exhales, the valve closes and air is pushed up through the vocal cords to facilitate speaking. The cap goes on the end of the trach to completely occlude the trach, as I showed you. And a patient cannot inhale or exhale through the valve and must breathe through their nose or mouth. So the trach cuff has to be deflated in order to use a Passé-Muir valve or a cap. If the cuff is up, the patient won't be able to breathe at all because the cuff occludes the airway, and the only way to get air through is through the trach. So if you occlude the trach and you inflate the cuff, no air can get through at all. The Passé-Muir valve and capping must be done in a supervised setting initially, just to make sure that the patient doesn't have any respiratory distress. Also, there's a thing called an HME, which is a heat moisture exchanger. This thing is an interesting little cap that you put on the end of the trach like this, and what it does is it keeps the heat and the moisture inside the trach, inside the airway, instead of losing it out into the environment, and it helps keep your secretions thinner so that you don't end up with mucus plugging. That's about it. Thank you.